Have you had any knee injuries or surgery?
No.
Okay. So just check the posterior tibial pulse, and then I take the shoe off and check the dorsalis pedis. You're looking for a joint effusion. When I look for a joint effusion, I always take my hand. I wonder if we could have somebody come in closer here and hold this. You think you can do that, Jamie?
Yep.
Thank you. Hang on, guys. We're going to work on something here. I thought I could get this to go.
No shave November, right?
Yeah, that looks great. You got to kind of tilt it back. Right? Yeah,
I
there
know,
you
I'm
go.
so paranoid. Oh,
Awesome.
well.
So joint effusions, what I always do, I'm going to come around this way. If you kind of squeeze up here and push the fluid down, that's the best way to do it. And then you can, the whole thing with bilateral patella, as you push the fluid down, there's going to be fluid underneath the patella, so it kind of bounces up and down. So you're just kind of pushing up and down if there's a joint effusion. But the bulk of the knee capsule is going to be above the knee. That's the suprapatellar pouch. So usually they're going to be swollen up here, and you compare it to the other side. And of course, you're going to check circulation, give the calf a good squeeze. Does that bother you? And we're going to check range of motion. So you always want them lay flat, so lay flat there. And I always say, does that hurt?
Hey, I hate to interrupt your demo, but we can't see her knee. All we can see is her hip and her upper thigh.
Was it better when we had it on the table?
No, because then I could only see her torso.
Oh, okay.
It needs to go to the camera left a little bit more.
Oh, okay. There we go. All right. And then I always do a log roll. So I just kind of document that the hip's not bothering her. So, I don't know what's the best way to do this. When you're palpating, I always bring the knee into flexion and palpate the tibial tubercle, patellar tendon, patella, and quad tendon. Give the fibular head a little poke here. And then this is going to be your IT band, kind of runs through here, and this is your lateral joint line. So I always take my thumb and I kind of give it a good, I go all the way around. Does that bother you? I give it a good squeeze in the popliteal fossa, and then I go to the medial joint line and work that around. So that's where you're going to be sore with meniscus tears. So lateral joint line, medial joint line. And this is a good time too. Can you make a muscle in your thigh and lift the whole leg up? So she's got a good straight leg raise. There's no question. Her quadriceps mechanism is intact, so you can document that. So patellar grind test. Well, first of all, patellar apprehension test is when somebody's either had patellar instability, subluxing or dislocating. You're just taking the patella and you're just pushing it laterally, and they'll stop you and they'll feel like it's going to dislocate. So I'm just pushing that laterally. They always go lateral. They are, just because of how the hips are aligned and the muscles, always want to pull the patella laterally. You can also do it medial too. Patellar grind test, you're basically reaching up like this, and you're pushing down on the patella with the C of your hand. And be careful with this one, because if it's a female with patellofemoral crepitus, it's going to really hurt their knee. It's going to cause pain. So I just say gently contract your quad muscle, relax, and you kind of push and I'll tighten it again. And I say do it slow and gentle, because if you do it real fast and hard, sometimes it crunches and they have pain the rest of the day because you just drove their patella into their trochleum. So that's already inflamed and all that. So from there, I just go right into my valgus stress. So I'm here. Put your hand on the outside of the knee, let your leg just go floppy. And you flex them to about 30 degrees, and you push like that. So it's a valgus stress. And then you want to compare that to the other side, see if it's lax. For varus, I bring the leg off the side of the table, do a little bit of flexion, and just the opposite. Don't see many LCL injuries, but lots of MCL injuries. For Lachman's, the important thing with Lachman's, big hands help because you have to grab around their femur, but you're grabbing here real firm, and then you grab the tibia and you kind of flex the knee, get them to relax. You're basically just holding the femur steady and you're pulling the tibia anterior. So I'm holding this, and that's the Lachman's.
And that's testing for
ACL.
ACL.
Yeah. And that one you got to practice. It's not really a watch and learn. You got to do lots of Lachman's. People that are good at Lachman's, they do thousands and thousands. Every knee we did in surgery, the first thing we do is we go up and do a Lachman's on it to see if it's. So that's Lachman's. And then if you have small hands, you can do the anterior drawer test. I'm sitting on her foot here with her knee flexed. The problem with this test is people tighten their hamstrings because they know it's going to hurt when you pull their tibia. So they try to guard. So if you take your hand and kind of push up in the hamstring tendon, she's actually relaxed. Most people aren't. I always put my thumbs, I kind of come down the condyles, and there's your tibial plateau. I put my thumbs on the plateau, and that helps me get a feel if it comes forward. So you're just pulling anterior. She's got a really good stable knee.
And that's PCL or?
That's ACL.
ACL too.
And for PCL, you got your thumb on the tibial plateau, you just give it a posterior push.
Okay, so posterior PCL.
The big thing about PCL, posterior drawer isn't really that great of a test because most people with PCL tears, when you're laying like this, your tibia is going to sag posterior. And if you go up to them and do a drawer, you're basically just pulling the tibia back to where it's supposed to go. It's sagged. And the way you compare that is you flex the other knee and you look from the side, and you see how Kim has this nice tibial tubercle? That basically disappears because the whole tibia is sagged backwards. It'll look different than the other side.
Ah.
So that's called the sag sign. That's a great test. That's the soccer player that was running and got tripped and smashed his knee into the ground, or the car wreck. Dash hit the front of the knee, push the tibia posterior.
And that's ACL injury.
PCL.
Oh, that's PCL.
Yeah,
Okay,
so
sorry.
posterior drawer, and then this would be anterior drawer. I'm pulling this way.
Okay.
But get good at the Lockmans. The Lockmans is your test. If you can get good at that, you're never going to miss an ACL tear.
Do Lockman's one more time.
So Lockman's is, I just hold it like this, real hard with my right hand, squeezing that femur. I grab the tibia and I pull it anterior,
Okay.
just like that. Yeah. You can also do pivot shift testing. We do that a lot in the OR because the patients have to be relaxed. So pivot shift test, I'm not going to make anybody. You're basically flexing the knee, internally rotating the tibia, and then you're going to extend the knee as you're putting an anterior force on the tibia. It's kind of hard to do. Everybody guards on this because when you crank somebody's knee like that and they're awake, it does not feel good. In the OR though, when you can't quite decide on those partial tears, they do that a lot to see if they're going to fix it.
Ah.
So the patient's asleep, they do a pivot shift. And it'll actually sublux anterior. You'll see it go plunk.
Wow.
So McMurray's, this is really important with your McMurray's testing. I always tell patients or providers, if you read it in the textbook, they're going to tell you to do all this valgus and varus. And to be honest with you, McMurray's test, for most meniscus tears, if you just do this and you flex her knee up, that's going to pinch her posterior horn of her meniscus, and that's going to hurt. If you did nothing else but that, you'd have a pretty good idea they had a meniscus tear. And then if you want to do McMurray's, so for the medial meniscus, I'm going to come around this way.
We'll see.
Yeah. So medial meniscus, you're just going to bring it in. Yeah, I'm putting my finger on her medial joint line. I'm going to tell her, this is where I want you to tell me if you have pain. You're going to sort of put this varus load on the knee, and then you extend. And sometimes you feel a click about that, right about. Usually it hurts when you do that. And as you extend, they'll have a little click on their medial joint.
And what's more common, medial or lateral tear?
Probably medial,
Okay.
yeah. But mostly because the medial meniscus is attached to the capsule and the MCL tears and their knee goes into valgus and they pull the capsule and it tears the meniscus. That's kind of the mechanism. So for lateral, a lot of surgeons, they just flex them up and they just kind of do this. They just kind of cram that knee into flexion and they rotate it internally. But if you do that and you put a little bit of a valgus stress on it as you extend, you're really pinching that lateral meniscus.
Now, it's so difficult on an acute knee because they're painful everywhere.
Yeah.
So, you know, it's just so hard to say what maneuver you do. If every maneuver causes pain,
Right.
and you're trying to diagnose it, it's
Yeah.
just so hard.
It is. And if you have a joint effusion, I'm never going to get you into that.
Right.
Because you're going to stop about there.
Okay.
So you really can't, when they have those big swollen knees, you really can't do a full exam because they're swollen. So, bounce home test. Bounce home test is basically just, I do that sometimes if I'm not sure about a meniscus. And all you do, you got to get them to relax. And they don't like this test because you just kind of go, like that. And when they hit that extension point, it kind of hits the meniscus and makes it hurt. So most people don't like that test. All right. Good, we'll fly through